That's a great session. Just moving on for the interest of time, it's great to be opening up this session. 3 fantastic speakers. Really excited to see what you all have to say. What we'll do, I see from the scheduling that we're going to have a discussion at the end. So after each speaker, we'll move on to the next. And at the end, we'll open up for discussion and questions. So let's move on. I'm going to introduce Dr. Andrew Krahn, who's going to be our first speaker on his approach to exercise in long QT syndrome and CPVT. So Dr. Andrew Krahn is professor in the Division of Cardiology at the University of...
Enough, I think
do you want to do it?
Who I am. Good morning. Good morning. Much better. Okay. Okay. I can give you 5 minutes back. I'll make this quick. Slides. Okay. Okay. Slides are coming. So for those of you who know me, so when I was a fellow 30 years ago, I was sent down to the exercise lab by Dr. Raymond Yee to supervise 2 boys named Trevor and Derek. Those 2 boys, their grandmother died 3 months after giving birth to their mother. And their mother had had a cardiac arrest on a treadmill. And they ended up, there was no genetic testing at this time, but they ended up realizing they had type 2 long QT. And I asked my boss, he said, go supervise the treadmill tests. These boys have something called long QT. And I said, what am I looking for? And he said, arrhythmia. And so I sat there and watched these 2 boys do their exercise tests, and their ECGs looked abnormal. And I was sort of struck by the fact that we didn't know what we were looking for, what was good or bad, what the right treatment was, what the cause of it was, other than it was familial. And I thought, this is very interesting, and I need to get to the bottom of this. This piqued my interest from a research perspective. And Trevor's ECG is enlarged and laminated behind my desk on the wall. Because I never forgot that. And those 2 boys grew up, and I fought with them about beta blockers and exercise. And there's some people in the room who I fought with about beta blockers and exercise. So let's talk about this. So good news, I've made an incredible discovery. It might be a Nature paper. I have found the cure for insomnia. And it's called Reading the New Exercise and Arrhythmia Guidelines. So, and you might notice here, let's see if I did this right. Yes, here's a couple HiRO internal folks. And here are some names of some people, including Cindy James, who's in our midst. And I don't want to stand in the way of our 2 great guest speakers in their talk. And other HiRO, our guest luminaries of Susan Etheridge last year, Mike Ackerman years ago, and so on. So this is a group of people who get together and basically invest an incredible amount of time trying to provide guidance on what's the safe and right thing to do for athletes. So here are the 106 publications that were cited related to inherited arrhythmia. So the good news is there's evidence. So back then, think of Andrew 30 years ago, flying in the dark. And now at least there's some evidence about what to do. And so this is specific to our field. So this is great. And so here's the key messages, and I might actually skip most of the rest of this, okay? And so the key messages here, I'm going to walk you through them one at a time. So one is the actual evidence that exercise is harmful or dangerous is very sparse. And there was this caution that came understandably when we were uncertain. And now a lot of evidence has been generated that in most of these conditions, exercise is good for you. And I strongly believe that being active regularly is good for our general health, for mental health, for physical health, for cholesterol, for weight control, for all those things. And that every hour you exercise, you don't need an hour of sleep. So exercise is generally safe, but it is the product of recognizing the condition, treating it appropriately, measuring that what you're doing is working, and if you like, making a contract together about how this works, which is also called shared decision-making. This idea, so this is not a, here, I'll tell you what to do. It's, let's talk about this. Let's strike a relationship. Let's be partners in how we go about doing this. What are the good things for you? What do you love to do? Because in the end, if it's an adversarial relationship, it won't work. So what you got to do is ask them, what's fun for you with exercise? What are the things you're committed to and those kind of things? And so, and we have good medical therapy. If we talk about long QT and CPVT, we have great medical therapies, okay? Not perfect, but very good medical therapies. And the team is a good part of this, because the other thing is, in my experience at least, the patient and the family we'll find some parts of the team more relatable than others. Sometimes it's the physician, sometimes it's the genetic counselor, sometimes it's the nurse or technologist, sometimes it's the medical student. And all those people are relatable. And it may be because, for instance, if your medical student looks like Shu Sanatani, you want to talk to him about exercise, right? Because he looks like an athlete. And so as a result, he's very relatable that way. So the second thing is that once they're on therapies and you have done something to show that the therapy is working, like you've beta blocked them, or their PVCs have gone away, or the fleconide's working for their CPVT, then that's necessary to say it's safe to return to exercise. And I'll show you that there's lots written about this. And then the other part of this is relationship-based, so socialize that recommendation around exercise. And when I say socialize, it's things like communicate with the team the person participates in, or they have the ability to say, this is why I bring an AED to my soccer game. Or you say that my running club is at least aware of this. So in the unlikely chance that the treatment isn't working, at least somebody knows. They don't have to read my wrist medical alert band to know that I have a medical condition that people need to be aware of. And then an expression I used that I think is pragmatic with patients is I tell them, exercise by all means, but my usual advice is an hour a day, 6 days a week is good for your health. Okay, after that, it's on you. Then you want to do it because it's fun, not because you need it for your health. 3 exceptions are hiking, biking, and walking. Good fun, it often takes more than an hour to do that. Okay, so not a lot of places are a great hike that's 30 minutes away. It's often 2 hours away. And then I say, work up a sweat, don't drown in sweat. Okay, and if you need a number, 130. Yes, I just completely made that up. Okay, but some people need a number, right? Because they're sort of doing this all the time. They're heart rate checking, and so that's what I tell them. And then with exercise, for instance, we exercise test all our long QT and CPVT patients to prove the treatment they're on is working. Okay, and so this is an example of what, for people who are unfamiliar, this is what guidelines look like. And so that's what those 109 publications, and as Cindy knows recently, in an immense exercise in dragging through all of this data to distill it into what seems like the recommendation for practice. So there's 9 for long QT, there's the 9 of them, and there's 5 for CPVT. Okay, and I won't go into the details. It's 236 pages long. It's available in open access online. And this is all that people read, but there's actually backup discussion about the content in it. And this is the section on CPVT and long QT. And we'll have the same thing for the other conditions our guest speakers are going to talk about. So here's the second patient who sort of taught me something besides Trevor and Derek. So this is Trisha. So Trisha is the smiling one with beautiful teeth, and she's a teacher in Oakville last I checked. And she is a wonderful young woman who was a teenager who I fought with about skipping her beta blocker on the day of her basketball games. Okay, because she played better when she skipped her beta blocker. And the problem was there were lots of tragedies going on in this extended family with CPVT. And this is Dan and their two kids, and a wonderful picture that she sent and posted on Facebook. And but it's a good reminder of the idea that we put her on beta blockers and did a cardiac sympathectomy, and she has done incredibly well. And she got back to driving, which was a big deal for her because she had so many cardiac arrests. And look at her smile. She's just very happy. It's very rewarding. So exercise is great. Make the diagnosis and treat it appropriately. Prove that your treatment is working, and then get them back to exercising and encourage them to exercise, and strike a relationship that allows you to support them in that activity. And I thank you for your attention.
Fantastic. Thank you so much. Let's move on to Dr. Dominic Abrams. So he's going to speak to us on his approach to exercise in hypertrophic cardiomyopathy. Dr. Abrams, I'm going to give you an introduction as well, if that's okay.
Okay.
He's a cardiologist and electrophysiologist in Boston. He trained in the UK and was a consultant at St. Bart's before moving to Boston's Children's Hospital, where he's the co-director of the Center for Cardiovascular Genetics. Great to have you.
Thank you. And a huge note of thanks to Jason, to Andrew, to Jeff for inviting me to the HiRO meeting this year. I've heard so much about it, and it's a pleasure to be here. So thank you very much, and very much looking forward to the rest of the symposium. So I think the important part of the title here was my approach. So I was really going to sort of reflect on that, how we handle these things, and how certainly we've learned over the years that approach has significantly changed for many, based on, as Andrew's already alluded to, evidence that has emerged as we become more familiar with these diseases and we see more patients with them. These are my disclosures. So I thought I'd start with 3 histories. The first is an asymptomatic 17-year-old who was a very competitive soccer player, still is. And when I first met her, the diagnosis in the family was known. It was known that she had it, but she didn't know about it. So this was known to her. She was actually in the middle of the recruitment phase for a collegiate scholarship at this point. She had the well-known troponin T mutation that was in the family. But otherwise, her investigations from an EP perspective, she had a normal Holter. And you can see her cardiac imaging down there. Her ejection fraction is good. She has no left ventricular outflow tract obstruction, no mitral regurgitation. She has the very classical thin filament phenotype with that sort of deep T-wave inversion on the ECG and apical hypertrophy on imaging. And her MRI only showed very discrete late enhancement. The next case is an asymptomatic 15-year-old who was picked up following diagnosis of a murmur. He was investigated, found to have hypertrophic cardiomyopathy, both on his ECG and imaging, as you can see there. More significant hypertrophy than the first case, with a maximum wall dimension of about 20 to 21 millimeters. And systolic anterior motion of the mitral valve with a little bit of MR, but no outflow tract gradient obstruction at rest, and some degree of diastolic dysfunction and left atrial enlargement with slightly more significant delayed enhancement. He had 2 variants, a very well-known variant in MYH7, which has been known for about 30 years, was one of the original Seidman families, and then an interesting MYBPC3 truncating variant, which again would be inferred to be causal to some degree, but the exact mechanisms are not yet alluded to. And then the third case is a young man who experienced a cardiac arrest playing basketball. He was not known to have HCM before this and had no prior symptoms. Genotypically, he was negative and had a normal Holter. And you can see the most sort of striking finding on his imaging down there on the cardiac CT was a myocardial bridge, which is about 20 millimeters in duration, or in length, sorry. And, but he reported no symptoms of ischemia, certainly no symptoms of ischemia before his arrest. And on multiple investigations, including exercise stress testing, every which way we could do it, there was no evidence of ischemic changes on his ECG. A sort of more concentric picture of HCM, maximum about 18 millimeters, and no delayed enhancement on his MRI. So those are the sort of the 3 cases, which we'll come back to towards the end as to exactly what we did about them. But just to review the sort of historical background related to exercise and hypertrophic cardiomyopathy. So the paper on the left is from the Bethesda guidelines. This is the 24th Bethesda guidelines, published in 1994 with Bill McKenna and Barry Aaron as the 2 lead authors on this. And at this time, hypertrophic cardiomyopathy was recognized or considered maybe to be the commonest cause of sudden cardiac death in the young. But they recognized that there was sort of a common sense approach was needed. And actually the evidence around this was pretty sparse. But this seemed like the approach to take in 1994. The relative risk in athletes was unknown. And they also recognized that there was significant heterogeneity in the phenotype, and therefore the risk that couldn't be better defined, and therefore sort of a blanket ban was sort of put in place, and everyone was restricted to that rather disappointing list of Class 1A activities. But cricket being on it as a Brit, we always take offense to that, but there we go. So that was the sort of the thinking at the time, but it was also known at that stage that there were athletes who were able to perform with hypertrophic cardiomyopathy to a pretty high level, and that was established at that time. And then this was then reflected in the first ACC and AHA guidelines in 2003. It was referenced to this study that athletes should be restricted. The evidence was indirect and circumstantial in terms of reducing risk. And this was also another study was cited, which was an Italian study. There were 49 athletes who died suddenly. Only one of them had hypertrophic cardiomyopathy. The majority had HCM. And 22 athletes were further disqualified from exercise. And there were no sudden deaths over a follow-up of about 8 years. And that was the evidence that was used to persist in this restriction for people with hypertrophic cardiomyopathy. So of course, the concern around exercise of any form in HCM is the potential arrhythmogenic risk related to a sort of a whole variety of different factors that vary significantly from individual to individual. The adrenergic trigger of exercise related to proarrhythmia, increasing in structural changes, outflow tract obstruction, mitral regurgitation. There's a sort of important component of microvascular disease in this condition. So are we producing more myocardial ischemia? Is that ultimately a trigger for arrhythmia? And then, of course, the potential for rapidly conducted atrial fibrillation in someone with restrictive physiology and left atrial dilatation. And then superimposed on that is the situational risk of dehydration, electrolyte imbalance, heat, cold, etc., that may be deleterious to these individuals. And therefore, this is obviously driving a lot of the concern related to exercise. But I think what's interesting when you look back through the data, and this was one of the large studies that was published in 2007, which was a sort of follow-on study to the initial one in the New England Journal in 2000. 506 patients with hypertrophic cardiomyopathy. You can see 103 or 20% got appropriate shocks. You can see the different rates in secondary and primary prevention there. And importantly, only 18 of the 51 patients with primary prevention ICDs only had a single risk factor of the 5 sort of traditional risk factors that we used to use considering implantation of an ICD. But when you study this paper, and the same was exactly true of the long QT history, the word exercise is not mentioned at all. And I think sometimes these are, you say, well, this wasn't part of the study, but I think sometimes these anecdotal findings are quite important. But in no situation was exercise mentioned. But things have evolved over time. Rachel Lampert did this study that actually showed a considerable number of athletes with ICDs can continue to exercise, including patients with HCM. You can see that 65 of the athletes in her study had hypertrophic cardiomyopathy, and they were much less likely to get shocks than those with ARVC or idiopathic VF. And so by 2015, when the guidelines, the Bethesda guidelines were rewritten, there was still this restriction in place related to Class 1A sports, but there was some leeway in that, in carefully considered patients who had been well worked up, investigated, and managed appropriately, there could be some shared decision-making in terms of allowing them to continue to exercise above Class 1A sports. But of course, the benefits of exercise, as we now know, are very significant. And there was a sort of a frame shift in thinking, certainly in my experience, in around the sort of mid-2010s, really reflecting the benefit of exercise. And rather saying, well, what can't they do? It was more of a frame, well, what can they do? And I think that was a sort of a very important frame shift in thinking. You can just see from this chart here the significant benefits of exercise. We all sort of learned that more than ever during the COVID experience. But I think certainly when you're thinking about younger patients and technically withdrawing them from sports and exercise, the mental well-being component is enormous. And for many of them, that team community, being part of something structured, having organization in their life is very significant. And when you throw out the figure that the suicide rate in NCAA athletes is only 10% that of non-athletes, it's a pretty sort of stark piece of data. So very, very important how integral this is to the lives, particularly of teenagers and young adults. And studies have continued to move forward. Vigorous exercise, this is the LIVE HCM study that I'm sure many people are familiar with, if not involved in. 1,660 patients with HCM. It was an observational prospective registry with self-reported degrees of exercise, and they divide them into vigorous and non-vigorous, and you can see there was no difference in risk between those who continued to exercise in a vigorous capacity, including those who did that on a competitive basis. And this is a study from Mike Ackerman on the right side, athletes, elite athletes. This is Division I or professional athletes who continue to exercise. The majority of them had hypertrophic cardiomyopathy, and most were able to do so very safely. 2 of them had symptoms, both patients with HCM. One had syncope, but he was managed with a beta blocker, and that spontaneously resolved. He's been well since. And one had a shock from his ICD while moving furniture, not in any way related to his sport. So as we've seen more patients and things have continued to evolve, the understanding that exercise is deleterious, certainly for all, is getting more and more sparse. And that's reflected in the guidelines. This, I feel, very up to date. This came out on Tuesday. But just as Andrew showed, I'm not going to go into this because you can all read this, but you can see that sort of evolution of thinking, that exercise is beneficial for the majority to a significant degree, and that even for those who want to continue in competitive exercise, they're able to do so if it's done safely. So our approach, what do we do? Well, our patient population is sort of, when I was thinking about this, it could be divided into three basic groups. Patients who are newly diagnosed with HCM, patients who are sent to us, usually with the caveat said, well, I've got this patient with HCM, I've told them they can never exercise again under any circumstances, quite common. And then sort of legacy patients who are now maybe in their late teens or early 20s, who've been avid members of the chess club since the age of 5, because that's what they were told they could do. And all of a sudden, we're reframing this for them and saying, well, actually, things are quite different now. And that's a kind of interesting discussion with those individuals who've been in this mindset for sort of 15 or 20 years. So it then comes, I think, to a very detailed clinical evaluation, both of the patient and the family, thinking initially about structural heart disease, what is the level of left ventricular outflow tract obstruction and mitral regurgitation, and managing that accordingly. Of course, initially with beta blockers, disopyramide, etc., but now for older patients onto direct myosin inhibitors. Important to understand their arrhythmic risk. That should be managed appropriately, as it would for people who do and don't exercise in the same way. So using the different risk algorithms and then addressing any sort of underlying supraventricular arrhythmias, which we just reported our experience of recently. Quite a significant number of them do have coexisting SVT, so making sure that is treated as well. And then sort of evaluating and understanding the potential arrhythmic risks of exercise. This is a 12-year-old girl who had sort of established disease from relatively early in childhood. This is the first ECG on her exercise test. This is the second, and this is the third. So this is not someone who you're going to allow to exercise under any circumstances. So we have seen this. It's rare, but you occasionally do see this very dramatic response to exercise. So understanding what is their potential and individualized arrhythmic risk. And this is another patient who already had an ICD, and you can see before she initiates into ventricular fibrillation, there's quite an increase in her sinus rate. This is a repeated pattern that we saw in her many, many times. Every time she got her heart rate up, it tripped her into VF. And so managing that sinus rhythm was able to significantly reduce her arrhythmia burden. But of course, this is not someone you would want to be exercising in this situation. But she actually had a sympathectomy and did extremely well from that, and is now back to very simple medication. And then I think finally understanding what is the functional performance of these individuals. I think what's really key here from our perspective is setting expectations. What do they want to do and what can they actually do? And it's very important to sort of balance those things to some degree. We had, many patients will sort of come in knowing this already. And we had a young man who came to see us recently. Him and his brother were very keen track athletes. And he just was aware that his brother was getting better and better and better than him, and he was not. And he was pretty static. And of course, he was evaluated on the basis of this personal history and was found to have hypertrophic cardiomyopathy. So he was just fundamentally limited on the basis of his structural heart disease. This is some work that Rob Shabilsky did when he was with us and showed that the important driver of functional performance largely is diastolic dysfunction for many of these individuals rather than outflow tract obstruction. So really understanding what they can do and setting expectations around this. And we've certainly had patients where the description of what particularly from the parents, of what they would like to do and what they're able to do are actually really quite different. And then, as everyone knows, it's very much a shared decision-making. It's a significant discussion. And I think time in this situation is an extremely important factor. Allowing people just to think through it, to process it, the sort of thinking fast and thinking slow approach, and coming to a considered occlusion is fundamental. We do have some non-negotiables. All parties must be aware of the diagnosis, as Andrew just said, and agree to them participating. I've only had one situation about 10 years ago where a coach said no. He said a friend of his died when they were kids and he wasn't going through that again. You have to play for a different team. But by and large, most people are very accepting of it. Everyone, teammates, coaches need to know how to use an AED, and an AED has to be there. Excellent hydration and diet, and then any symptoms lead to immediate cessation of exercise. That, of course, is on the individual, but most of them are pretty responsible. But this is set out very clearly for them if they decide to return. So the three cases I presented, the first was a highly functional athlete, as I said at the beginning, and she was recruited to college. She's continued to play. She's doing very well and remains entirely asymptomatic, really reflecting that very early experience that it was known that some people can continue to do very well at a high level in terms of exercise and sport. The second case was more interesting. He was enrolled in our cardiac exercise program, which has been a fantastic addition to what we're able to do. And as you can see, the benefit he gained from this was very significant. He lost 60 pounds in weight. His VO2 max increased by 17%, and his upper, lower, and core strength all increased significantly as well. But I think what was the most important thing was his personal engagement in this. He completely transformed himself. And as the girls in the exercise lab were telling me, he went from a sort of monosyllabic 16-year-old boy, which I can say because I was one once, to a sort of a much more engaged and animated. He took huge personal responsibility. And as you can see, he went from sort of being an also-ran at the back of the team to starting for his football team. So it was a sort of a significant personal transformation for him as well in terms of exercise. And the third case, we sort of analyzed him in great detail. There were multiple conversations with the family, and we discussed the myocardial bridge in great detail. It was not thought to be of any significance. We have a joint meeting with the Brigham and Women's. He was discussed there. Charlene Day, who's led a lot of the exercise studies, joined us for that meeting. And it was felt that he could, successfully go back to exercise with the usual provisos that I just spoke about. When he was extubated after his cardiac arrest, the first thing he said was, "When can I play basketball again?" And this was just something that was really intrinsic to him. And every time we saw him, "When can I play again? When can I play again? When can I play again?" So we were very excited, and we sort of said, "Listen, we've had a really detailed discussion." We got him back to clinic, and we told him, we said, "We think you can safely go back, but this is the way we want you to do it." And he said, "I've actually discovered this thing called art. It's really cool, and I really like it. So I'm good. I'm going to just do my art. Thank you very much." So I think that's a really important point. Give people time to reflect on what's really important to them, and that some people actually just decide not to. That's a really important point. A significant number of people say, "It's fine. I'm just going to do what I'm going to do," and I think that's appropriate. But obviously, we now know that exercising to a moderate degree, just living a healthy lifestyle, is very important. Just a sort of a quick look to the future. This is a kind of interesting paper that came out from Ewan Ashley and his group very recently, looking at sort of multi-omics in exercise. And then I think my point here is that we're understanding exercise in a very different way, and that's going to continue in the future. What do these specific genetic mutations mean in response to exercise? What are the other changes that we're seeing, not just in people who are endurance athletes, but also in people who have underlying heart conditions? So an exciting time in the future, as has already been echoed this morning. So just to conclude, there's been a marked evolution of our understanding and the benefits and risks, and I think that ratio has significantly shifted towards the benefits over the last 20 or so years. I think this really reinforces the need for centers like all of ours, because patients do need a lot of help and care going through the process about exercise, and a lot of people don't want to take that responsibility on. That's fine. That's why we have centers for inherited heart disease. The majority of people with HCM can continue to exercise safely, even to a very high level, but the approach should be personalized and they should do it safely. And then I think as the future develops, we really should be thinking of detailed evaluation for all these patients. I'd love to put everyone through the cardiac exercise regime that I showed you. For that one individual, it's just getting space and time in the lab. And then for the future, thinking how things may evolve at a much more nuanced level. So thank you very much again for your attention. Thank you for the wonderful invitation to be here, and I look forward to the discussion at the end of Cindy's talk. So thank you.
Absolutely fantastic. Thank you so much. So my pleasure to introduce our next speaker, Dr. Cindy James. She's going to speak on the optimal exercise prescription in ARVC. Dr. Cindy James is an associate professor of medicine and genetic medicine and a certified genetic counselor at the Johns Hopkins University, where she serves as the research director of the Johns Hopkins Center for Inherited Heart Diseases and the Johns Hopkins ARVC programs. Her research focuses on investigating the interplay of genotype and environmental factors on clinical outcomes in ARV or in the arrhythmogenic cardiomyopathies, and on optimizing cardiovascular genetic counseling service delivery and outcomes. Pleasure to have you. Thank you.
All right. Well, thank you so much, everyone. And I recognize I am the last speaker standing between us and the break, so I'll try to make this efficient. And in doing so, I'm lucky that all the previous speakers this morning have set me up very well. So my task this morning is to discuss what is an optimal exercise prescription in ARVC. For those of you who I don't know, as I said, I'm a genetic counselor and geneticist. I've spent my entire career in Baltimore. in part working with the Johns Hopkins ARVC program, which was established and still is led by Hugh Calkins, who was already mentioned this morning. One thing our center does is spend considerable amount of time investigating the association of exercise with ARVC. So my title was, what is an optimal exercise prescription? Well, I'm a genetic counselor. I don't write prescriptions. So I have reframed this as, how do we come up with an evidence-based, individualized exercise guidance and decision-making approach for our patients? And in doing this, I'm going to spend a couple moments level setting. What do we know about exercise in ARVC? And where did our recommendations stand starting about 5 years ago? Going through what I believe are important patient-related factors as you consider exercise factors themselves, and importantly, the interaction between those two, and finally touch on shared decision-making, the importance of patients' preferences, values, and goals in coming up with individualized exercise guidance and decision-making. So to begin, the background. So to level set, what do we know about exercise for ARVC patients? I'm defining patients as those who fulfill a definite diagnosis per 2010 task force criteria. So we know from a number of studies over the years that competitive and frequent vigorous intensity endurance exercise, so high dynamic component, high VO2 max, is associated with earlier onset of ARVC, worse survival free from sustained ventricular arrhythmias, worse right and left ventricular structure and function, and an increased likelihood of developing heart failure. And that data is fairly robust. This has been replicated by a number of groups, a number of studies measuring exercise in a number of ways. Because of that, this is part of an HRS guideline we put together 5 years ago on ARVC. Historically, the guidance has been that vigorous intensity activities, which are these with high METs in the red and orange, should be rarely done, if at all, and lower intensity activities more regularly. But what I want to highlight this moment, that is a blanket recommendation. It's not differentiating patients by genotype or the nuances of their phenotype. Situation for our genotype positive, phenotype negative relatives is that the data is really sparse. We think exercise in at-risk relatives is associated perhaps with a dose-dependent increase in penetrance, a dose-dependent association with the extent of RV and LV dysfunction, some evidence of a greater likelihood of incident ventricular tachycardia, but overwhelmingly less data. This is a study we did a couple of years ago on a gene positive relative only cohort, 101 relatives, big for ARVC, but clearly a relatively small cohort overall. It certainly showed those associations that I just described, that higher levels of exercise are associated with higher penetrance and somewhat higher likelihood of developing a VT. But look at that, 82 of these 101 relatives have a PKP2 variant. This is a PKP2 study, not an overall ARVC study. All right, and because of the relative weakness of this data, and frankly the fact that ARVC is a disease associated with age-related incomplete penetrance, and we know not all relatives, including not all athletic individuals with ARVC-associated variants ever develop disease, the guidance even 5 years ago was clinicians should counsel that exercise is associated with an increased likelihood of developing ARVC. Again, not individualized. So I've just referred to the importance of genotype and cardiomyopathy type factors in the association of exercise with outcomes in ARVC. So where's the evidence? Well, we've known for a while that gene-elusive ARVC, in the absence of a family history, occurs overwhelmingly in very high-level athletes, people who have done very frequent high-intensity exercise. So the very tall blue bar here that you're looking at, gene-elusive, no family history, has done twofold the accumulated MET hours per year of exercise compared to the people in the aqua, who are individuals with a desmosomal variant, who themselves are disproportionately athletes. That is aligned nicely with work done by Andre Lagersh, Heinbuchel and colleagues, who had postulated an exercise-induced form of ARVC, presumably in individuals at some level of genetic risk, in which repeated bouts of extreme exercise make the phenotype occur. And then when we look at the benefit of reducing exercise after diagnosis, again, this is a study we did a couple of years ago looking at 129 ARVC patients with ICDs. Unsurprisingly, we found that the patients who had cut back most on exercise after their initial clinical presentation had a substantially lower risk of having a first sustained ventricular arrhythmia compared to people who cut back less. And even though this is a trend rather than statistically significant, it appeared that people who were gene elusive, it says mutation negative here, disproportionately benefited from cutting back on exercise, which sort of makes sense if you think about the pathophysiology that's postulated. All right, so that was gene elusive versus gene positive. What about specific genotypes? I've just told you that there was a strong association between exercise and ARVC versus worse outcomes. That does not seem to be true in patients with a Dutch founder variant, ARG14-del, associated with phospholamban cardiomyopathy. In these survival curves, you can see that the red line, more active patients, and the blue line, less active patients, if we take a look at their lifetime exercise, active patients are no more likely than inactive patients to have an arrhythmic event, to have a first hospitalization, to be diagnosed with ARVC, or to be diagnosed with DCM. The question that I'm asked on a weekly basis, including by some of you in this room, is what about desmoplakin? We are increasingly understanding the phenotype of desmoplakin cardiomyopathy, the risk factors associated with worse clinical outcomes. Even in this seminal study by Eric Smith, Adam Helms, and colleagues out at the University of Michigan of 107 patients with pathogenic or likely pathogenic desmoplakin variants, just in looking at the clinical record, it looked like exercise history was less common in their probands, and there was no association with VTVF, very different than what you would see in a usual ARVC cohort. So we took on this challenge and have recently completed a study of exercise in desmoplakin cardiomyopathy. Similar to work we'd done previously, we took 100 people with a desmoplakin pathogenic or likely pathogenic variant. We did interviews assessing their lifetime exercise history from age 10. This is similar to how we study exercise in general. And here you can see we got complicated results. So the athletes, which are defined as met hours per year of vigorous intensity exercise greater than 24, so the athletes in red and the non-athletes in blue had similar lifetime survival free from a first heart failure episode requiring emergency room visit or hospitalization. No difference in lifetime survival free from a first sustained ventricular arrhythmia. That looks different than PKP2, but what we were seeing is that our athletes were significantly more likely to have a lifetime first myocardial injury episode. And these are these episodes that we see overall, of course, in ARVC, but disproportionately in desmoplakin, in which people have really an episode that looks like myocarditis. We're calling it myocardial injury. That is bad because these myocardial injury episodes are associated with very elevated increases in the risk of incident sustained ventricular arrhythmia and heart failure thereafter. So our hazard ratio in a time-dependent analysis after myocardial injury is 8 for VA, 10 for heart failure. And this is just published data on a smaller cohort of our own DSP patients that we'd done previously, again, showing that after myocardial injury, the blue line, patients have a far worse outcome. All right, so fortunately for me, Andrew already introduced the recent HRS document. So we spent a lot of time on genotype-specific guidance for exercise and arrhythmogenic cardiomyopathy. We did a deep dive into the evidence of what the actual evidence of vigorous endurance exercise is with clinical outcomes in the various genetic ACMs. And you can see the evidence is very strong for PKP2, the gene elusive, and then you see a lot of question marks. That's just an absence of evidence. And I think what you do with an absence of evidence is pretty complex. And this is, again, like everybody else, I'm not going to walk through this, but the take-home message is there's now genotype-specific guidelines in that I think are hopefully going to be more usable. All right, so I talked about genetic factors. What about exercise factors themselves? So AHA recommends at least 150 minutes per week of moderate intensity aerobic exercise. If you calculate that out, that's a minimum of 7.5 med hours per week. But then, so exactly what type of exercise? This is a really nice study done a couple of years ago by Kristina Bangma's group from Oslo that took a group of their ARVC patients and family members. This is, again, going to be almost all PKP2. And as you can see from this figure, high-intensity exercise, as you'd expect, was associated with poor outcomes, particularly sustained ventricular arrhythmia, independent of the duration of exercise. But the good news here is that lower intensity exercise, regardless of long or short duration, was associated with considerably less risk. We also have evidence coming out of Andre Lagersh's group that static exercise may be safer for ARVC patients. So if someone really wants to go to the gym, do toning on the weight machines rather than run on the treadmill. So how much exercise? This is a study of 106 ARVC patients from the Netherlands, Hopkins, and our colleagues in Norway. And what is in the red box is showing you that the substantial increase in risk here of sustained ventricular arrhythmias elevates significantly at fourfold the AHA minimum. There's a lot of room there for people to be active before you hit that point. What about for family members? We took this approach. This is a PKP2 specific study. This is a pedigree-based assessment. Again, looking at the amount of exercise they're accumulating over the course of a lifetime. And at the time of diagnosis, these family members had done, of the ones who were diagnosed, threefold the AHA recommended, and at the time of first arrhythmia, fourfold the AHA recommended minimum exercise for healthy adults. Again, suggesting there's some wiggle room here. And I just want to remind this room, and we have this conversation with our patients, there are many benefits that accrue from modest amounts of exercise. Admittedly, if someone really wants to be a competitive athlete, that's a challenge, but there are many benefits at these twofold, threefold AHA recommended levels. All right, and I'm going to wrap up this talk by talking about the importance of these ongoing conversations with patients and families, alluded to by both of my colleagues. One interesting thing when you set out to evaluate shared decision-making is different fields have different definitions of exactly what this is, but I think most of us agree that it includes taking the best available clinical evidence and integrating patients' preferences and values. We took the opportunity, actually in partnership with Susan Christian, who's here today, to look for the evidence. What's the evidence that shared decision-making works? So and how often does it happen? We did a questionnaire-based study to define the extent and implications of shared decision-making for decisional conflict, decisional regret, and really the final exercise decision. And this went to 194 ARVC patients and genotype positive, phenotype negative relatives, and our response rate was good, which we felt good about. There is a really wide range in the extent of shared decision-making happening. So that shared decision-making score goes across the whole scale, 0 to 100. Of interest, shared decision-making was more common in patients diagnosed as adolescents. I don't know if it's something about them being adolescents or perhaps pediatric cardiologists are just better at this, but that was something we found. Very clearly, shared decision-making was associated with better psychosocial outcomes, less decisional conflict, less decisional regret. That's important. Also, really interestingly, these are ARVC patients. Most are not doing particularly high levels of vigorous intensity athlete, but there was no difference in the exercise choice made. So better psychosocial outcomes, no difference in ultimate choice. So what would be my optimal exercise prescription? Well, I would say that frequent high-intensity competitive exercise in ARVC patients with high-risk genotypes in the context of exercise optimally will be limited. So where is there strong evidence? PKP2 and gene-elusive ARVC, there is strong evidence that exercise increases worst outcomes. I think the evidence is very strong in TMEM43 as well. I am pleased that I guessed right that that data was already covered today. There is some, but weaker evidence, admittedly, for desmoplakin, lamin, and DSG2. AHA recommended minimum exercise for healthy adults really should be generally encouraged to pretty much almost all our patients, with some exceptions. And the risk of these arrhythmias seems to elevate most at fourfold AHA recommended minimum. There's wiggle room. Static exercise may be safer. For these relatives, this is a shared decision-making counseling conversation. Certainly, it's worth increasing screening in those who choose to participate in competitive athletics, particularly PKP2 patients, where we know that sudden death in the concealed stage is a real risk, particularly in younger individuals, and shared decision-making for all. Better psychosocial outcomes, better partnership with your patients, really no downsides. That's our practice in all patients. All right, and thank you very much.
Another fantastic presentation. I also have to just apologize to Dr. James for the name change on the program and on the bio that was given to me. Apologies for that. We'd love to open this up for questions from the floor, and I'm sure there's lots of questions as well. Maybe I'll start quickly if that's okay. There's a lot of difference in the recreational athlete and an exercise prescription and someone who's competitively training who wants to go back. How do you structure that in your clinic? Are you giving them a more structured written program, something that's going to their coach? How do you do it in that more competitive individual?
So so that's specifically in the context of ARVC patients? Frankly, we have very few full ARVC patients who meet 2010 task force criteria who go back and pursue full competitive exercise. The evidence is pretty strong, and I mean, are there a handful of people who do it? Absolutely, but that's pretty rare. So most of our conversation, frankly, is in the context of recreational exercise. And in that sense, do we give them a written exercise prescription? No. No, we do not. These are conversations.
Yeah, I mean, I think particularly in your group, it's a slightly easier discussion, but within the hypertrophic group, it's a different issue, isn't it? So the question was kind of for everybody, really, because it's nuanced to each individual.
Yeah, so we try to use the exercise strategy that I talked about. We'd love to use it more, but really to give people a specific program to work towards and understanding what are their goals from this. You know, what do they want to do? What do they want to achieve? And sort of, as I said, setting those expectations, saying, listen, this just isn't going to be achievable for you. We think here is better. And I think certainly for the younger patients, a lot of it is confidence, particularly people who've been restricted in the past, just allowing them to, but they said, well, I was told it would be a disaster if I exercised. And that's often the words they use. Allowing them to actually do it in a safe environment is hugely beneficial to them, we found.
Yeah, I might say, I think one of the ways to approach this is to ask the patient, what they brought to the table. And so a good example is between the care providers before we met them and the internet, there's a lot of, and I guess social media is part of the internet sort of bucket. There's a lot of, they bring a lot to how they think about this. And then if you listen to that, then it helps to understand what it is that's rewarding or interesting or that they like about it or want to do. And then you ask yourself, okay, do they have expectations that have the potential to be not in their interest? I don't like, when can I play basketball, right? You wake up after your basketball cardiac arrest. As opposed to most often, in my experience, I guess I would say, they have reasonable expectations, and they've just somehow thought that they cannot do anything. They have to play tiddlywinks or bowling, right? And that's because, the internet has got more of that legacy kind of language in it than the modern thinking. So I think it's usually not hard to make a contract, if you like, a social contract with them to land on some common spot. Periodically, though, sometimes what happens is you say to yourself, okay, a year or two from now, it would be nice if we got to this point. And so now this is somebody who, for instance, I'll book more follow-up, more in-person or more conversations with a person who says, you don't understand. I'm going to pursue MAID if I can't run marathons. And I've heard that before. And then you say to yourself, okay, this is a project. This isn't a consultation, it's a project. And then you go down that road. So I think this is usually pretty workable. And the other thing I say is, I don't make decisions. I give advice, you make decisions. Give them the power. And then all of a sudden I think it flips, because then they sort of respect you as a person who, okay, you're a resource for me to make a decision, as opposed to the other way around where I have to do what I'm told. And I think that's very helpful for the idea of getting to the point where you land in a common space. You're comfortable, it's safe and best for them, and they're comfortable that when they're doing it, that it's okay.
I think Dr. Dorian has a comment.
I have an observation and a question for the whole panel. I'm speaking as an adult sports cardiologist, where most of the patients I see are between 25 and 85. The observation is that our ability to assess the intensity of exercise is extremely poor. We've done this objectively. Most of my patients who are a little bit older, young middle-aged or middle-aged, will not even put their shorts on for 6 minutes of exercise. They regularly exercise at 12 METs or higher when measured objectively. And we have some recent data that shows that really fit people greatly underestimate the effort level required, and less fit people greatly overestimate the effort level required. So unless you actually measure watts of output or time on the erg or minutes per kilometer, take into account weather and wind and so on, very difficult for the subjects, for the patients or the athletes or the caregivers to know exactly how hard they're working. And I have a great sense of discomfort with those tables. Competitive singles tennis can be extremely highly demanding, but some people bicycle at a slow rate, and they enter races, they enter 10K races, but it takes them an hour and a half to finish 10K and they're walking. So I think we need to reframe the way we think about what we mean by the particular sports that are being talked about. So the observation or for comment from the panel, the other issue is that for most of us who do more adult sports cardiology, we tend to see patients in their 30s and 40s who have identified disease, but they've lived a lot longer, and they have both their risk may be different and their perspectives may be different than an 18-year-old. So we need some help in sort of thinking through how to deal with somebody who's already had 40 years of risk with not necessarily any outcomes.
10K in 90 minutes isn't bad. Walking, as a walker.
Can I interject here? I'm a patient. I have ARVC, and I was a professional athlete at one point, and I'm a recreational athlete. And so my question is not to complain about my treatment. I'm very happy with my treatment. But it is on behalf of patients, and it's exactly that. As sports athletes, it's very difficult for us to assess what is easy, what is light. I've been training all my life, so for me, doing a 2-hour bike ride, that's an easy, light workout, mountain biking or doing something like that. So as we are allowed or permitted now more to make decisions for ourselves, this is the question for the panel, what kind of diagnostic tests would help us decide whether our exercise has gone a bit too far? And how frequently should we be asking for these tests to be done? And I know it's going to be different across all the different situations, so I don't know if you want to individually answer the question.
Thank you.
You can start.
Yeah, I agree with both the points. I think it's very difficult to accurately determine exercise, particularly on a historical basis. There was a study in Scotland where they asked a bunch of teenagers how much exercise they'd done the week before. The boys overestimated by 20%, the girls underestimated by 20%, which was an interesting finding, not surprising. So I think it's very, very difficult, but I do think that the way we ascertain this at the moment is pretty crude. And we need to sort of get much better at doing it and how we understand it. That's going to be a whole new sort of evolution of cardiology. But, you know, I think in the absence, at the moment, in the absence of phenotype, if we can measure things objectively, certainly in HCM, we look at their exercise performance, and things, you know, to all intents and purposes otherwise remain stable, then it's, we seem to be on a steady and a good track. But what is happening at a more nuanced, at a cellular level, who knows? So I do think we're just starting to dip our toes in the water of this, and there's a lot more to understand. And of course, historically, we didn't have these cohorts to study because they were all restricted from exercise, certainly in HCM. No one did anything. So you didn't have any idea what exercise did. So I think it's very early days, but I certainly agree with all your points, and your points as well. Hope that we can understand that better in the future.
Yeah, and certainly, I mean, I'm the one who put the tables up. There's a citation. I mean, it's from the Compendium of Physical Activities. It's Barbara Ainsworth's sort of life's work doing that. But absolutely, it's a hugely limited retrospective data collection of historical exercise is challenging. We do these interviews. There's a whole art to it. It is imperfect. It is error-prone data, but it's better than doing it by questionnaire, and it's sort of the best we've got in terms of figuring out what is there an association or not. I think the answer of, so what do I do moving forward, is really where the data is lacking. What you'd really want to do is a prospective trial. That's hard. The numbers are small, the follow-up time is long. So it is error-prone. You're absolutely right, but it is also probably the best we can do until we get those prospective trials moving forward. In terms of what can we do to evaluate the risk of exercise, I will tell you, at least in our program, we are big fans of Holter monitoring. We believe, and data supports this, that sort of a PVC spike, a rapid increase in PVC count, is an early warning sign of an arrhythmic hot phase. And so for our patients who do lots of exercise, who make that choice, we do every 6-month Holter monitoring because we think it's a good early warning sign. I know a lot of people are fans of the exercise treadmill test. We don't use it very often clinically in ARVC. We don't find it especially helpful in this condition. Yeah, and certainly for a genotype positive, phenotype negative individual, particularly for someone who's younger, who's playing competitive basketball or whatever, that really is just a more frequent evaluation schedule than we would have for a teenager of a similar age who was not competing.
I think it's an excellent question remark from Ms. Bangma, because I agree with my colleagues and the speakers. Our tools are very crude and poor. We use in adults very often the treadmill test because except for like the CPET and the bike, this is all we have. We know that we talked a lot about intensity. We also know that for the same heart rate, the adrenergic tonus can vary substantially. We had patients for the same heart rate on the treadmill who didn't do a single PVC, and you put them on the bike and they went into a sustained VT. Other individuals experienced their arrhythmia while playing volleyball. Obviously, in the healthcare system, we cannot imitate all that. And the reassuring effect, it reassures psychologically the doctor. Some patients, from my own experience, I can say we have we had patients. For example, I have a family of 2 brothers with a TCRL syndrome, like a long QT CPVT type kind of syndrome. The younger one had a cardiac arrest, had already an ICD, and the brother, both were on appropriate beta blockers. And we did once, twice years a treadmill, was great, and we felt confidence. And like the older brother, after a while, just a few weeks after a unremarkable treadmill, went into cardiac arrest during the warm-up in the gym. So these are, unfortunately it went well. He got resuscitated, has also now a defibrillator. However, this humbling and frightening experience shows how poor our tools are. So even if we would do it every year, I think it's probably meaningless for many patients, because there's a lot of things we don't understand, the role of the autonomous nervous systems. I personally, we do Holters and this stuff. I'm not such a big believer because it's cumbersome for patients. They don't like it, even like patch monitors. I think an interesting role might play intelligent devices like wearable watches and patients forward as data. They collect their own data because, yes, we need more data in trials. It's hard to do. I think we should use these novel tools to integrate small information, PVCs. At some point, Apple Watch and company will be able to calculate T-wave alternates and all these things. I think this is like maybe an option.
Okay, you probably have to, moderators got to keep us on time. And do you want to finish?
I just think that we're in a world and a life where everything is being videoed, everything is being measured. We have smart homes, mattresses, shirts, toilets, I heard recently. Kind of scares me a bit. But I mean, if you look under the health app on your iPhone, it tells you actually a lot, including heart rate variability and so on. And there's, so I think the wearable area is going to be very informative because it's the real world data, at least on heart rate aspect of things. And these things are pretty accurate. And I would agree with about the ARVC and treadmill testing. We stopped doing them, and I just tell people exercise on the day you wear your Holter. So